Hello everyone, this is Sean Fox from Carolina's Medical Center. Thank you for returning to the Pediatric EM Morsels ReMastered. This is our second edition, and today I wanted to talk about something that most of us are probably very well accustomed to managing and feel pretty comfortable in the clinical decision making, but sometimes I think that is still a good area to cover just to make sure we're all on the same page. We're going to talk about minor closed head injury in children now. Fortunately, most of our kids nowadays have helmets that are a little bit more robust than this pumpkin has today. However, they still do excellently fun things like extreme sports and riding on motorized scooters when they're only 5 or 6 years old, or certainly ATVs are quite prevalent where I live now, and or they just have shoes that have wheels on them, and they like to fall down in the mall. We all know that significant head injury is the leading cause of morbidity and mortality worldwide in children. So we're acutely aware of its management and need for prompt intervention. But fortunately, we see a lot more minor head injury, certainly those classified as having GCS of 14 or 15 with no obvious neurologic abnormalities. But because of our fear for the epidural hematoma, certainly with the media continuing to support the need for constant vigilance for this, we are always posed with the question of the child presenting who appears well now after what seemed to be minor head injury to us, but apparently more concerning to the family. We have to determine at what point do we need to image these children. And fortunately for us, it's been well investigated by the PCARN network, a network we all know and love for all of the work they've done and for the education and information they've given us to help us develop the guidelines. And again, remembering that the majority of kids with minor head injury are going to have normal head CTs and even more rarely require any neurosurgical intervention. Our goal is to not use any tools unnecessarily, so not to over-irradiate kids just because they had a slip and fall. Now, how does that bear out? Well, we all know that for kids that are greater than 2, if they have no mental status change, their GCS is normal, they've got no signs of basilar skull fracture, that they don't need a CT right away. But you need to start considering it if they've got persistent vomiting, severe headache, have had significant loss of consciousness, or their mechanism is severe. Or in addition, or in counter-distinction rather, you could observe them. And this is where the conversation with the family is going to be most important, I find, because if your decision to observe the child in the end leads the family still requesting a head CT, and the child has had significant mechanism or still complaining of a severe headache, we should have had this conversation at the beginning and determined what was the best course of action instead of waiting several hours and then determining that the family wanted a head CT anyway. But there's certainly going to be patients that you just are very confident that a head CT is not going to be in their best interest. We'll talk about being able to explain to the family the true risk of radiation in a moment, but first let's further elucidate the fact that the second group, the kids that are less than 2, really warrant a little bit more consideration. Why? Because that group of kids is vast in developmental stages, right? This is where all of our significant developmental milestones are occurring in those first 2 years of life. So the thought that a 3-month-old or a 2-month-old fits as easily into this guideline is a little harsh. So I would say that one moral that we need to consider is that those kids that are less than 3 months of age really need to have a little bit lower threshold, if not a lot lower threshold, for neurologic imaging. Why? Because that kid who's less than 3 months of age has very thin skull, so has less protection. Additionally, they've got less ability to demonstrate that they've been injured to you. Their interaction with you, their social interactions, are much more limited. It's not until that 2 month of age that they really start to interact with the world, and they might have some improved head control, but it's not the same interaction that a 6-month-old will be having with you. And because of this, the idea that you can observe a 2 or 3 month old for some time and feel better that they've got no intracranial hemorrhage is a little misguided, because your beginning examination was somewhat unreliable. So observing for any change over that time period is not going to generate a significant or more improve the reliability of that exam that much. So I think that it's important to realize this, and it's even spelled out in the PCARN guidelines. While they did look at a lot of children, 25% of the population was less than the age of 2, they further define that less than age 3 months is a special population. They just don't have a specific guideline for it. So in the end, age 2 is a big group, and you really should have a higher index of suspicion and a lower threshold for imaging in those kids that are less than 3 months of age. Well, the family needs to know, when you're discussing with them the risks and benefits of observation versus radiation, what really the risk of radiation is. They've been watching the news, and they are aware that you've been setting off multiple atomic bombs in your emergency department and hospital daily. Well, that's obviously not true. We'd all be glowing a little bit. But what is true is that the lifespan studies were able to look at medical dose radiation, 0 to 100 millisieverts, and were able to find that there is significant increase in lifetime attributable risk to cancer when you're exposed to these medical dose radiation. What is our baseline risk, however, is important to know. Our baseline lifetime attributable risk is 42% based on a 3.5 millisievert dose a year. 42% chance I'm going to develop cancer in my lifetime. It's very scary to me. But if I give someone 10 millisieverts of radiation, I increase my risk by 1 in 1,000. So I went from 42% chance to now a 42.1% chance. That just doesn't really seem to be that significant. If I have a slip and fall, scan my head by all means. But wait a minute, 0.1% of a population is a huge number, and we have seen notable increase in cancer rates because of this. So it is an important thing to realize that 0.1% at 1 in 1,000 risk is important. It is statistically meaningful. More important is that the population we're talking about, specifically in kids, are more susceptible. Their risk is even probably larger than 0.1% because they have more mitotic divisions occurring than you and I do. They also have a longer time for an individual proto-oncogene to be turned on and turn into an oncogene and to develop into a tumor. They also have a longer time to accrue more radiation. Remember, you don't get rid of the radiation, you continue to keep it. And unfortunately, one CT often begets another CT. Well, all of this is great, but telling a family that they've increased their child's risk of developing cancer by 0.1% is, one, not completely accurate, and two, difficult to hold on to in a tangible fashion. What is more tangible is being able to tell a family, look, a chest x-ray gives you about 10 days worth of radiation. All right? If I think you have pneumonia, 10 days worth of radiation, not a big deal. All right? But a chest CT gives you 2 years worth. A head CT is in the middle, gives you 8 months worth of radiation. So the question we always have to answer for ourselves and help our families that we're caring for answer is the risk of your patient or their child of having an intracranial hemorrhage or injury greater than the risk of 8 months worth of radiation? That's the question. That's the balancing act that we have to do. And is there a way that we can avoid doing the radiation and remove that from the equation and still be able to ascertain whether there's any intracranial hemorrhage or injury. And that's where observation comes in. Now, there's going to be some families that after having this conversation aren't going to be able to sleep at night, knowing that there's a small, minuscule risk that their child has had some kind of intracranial hemorrhage, even though the risk is minuscule and that after observation it's still going to be infinitesimal, and that the likelihood of them needing any neurosurgical intervention is almost zero. They're still not going to be able to sleep. If you're falling in this gray zone and you're reaching kind of an impasse, as long as you're able to explain to them that this is kind of the risk that we're dealing with radiation-wise, and you're comfortable with the plan and they're comfortable with the plan, I think having a very open conversation is going to lead to better patient satisfaction and, in the end, improved outcomes overall. So I hope that was helpful, and I also welcome you to comment. Send me emails directly to smfoxmd@gmail.com, or certainly you can add comments on the website at pdmmorsels.com. With that, I thank you for your time, and I look forward to talking to you later.